So these are used and are approved for advanced disease, but only once you've had hormone therapy and once you've had chemotherapy. What we're hoping is to get those introduced much earlier in the treatment pathway, particularly for newly diagnosed men. There's a lot of evidence now to suggest that men who need hormone therapy do much better if they're given another therapy at the same time or within 3 months. And that normally is docetaxel. There are some new drugs coming on. They're all utamides. Apalutamide is going up for appraisal as we speak, indeed, as is darolutamide. One's made by Janssen, the other one's made by a firm called Bayer. The fact that drug companies are still putting money into this field makes me realize that, they obviously, A, that we know they work, but B, there must be money to be made, because they wouldn't put it in, they wouldn't be doing the research if they didn't think they'd get their money back. So these drugs may well come on stream. Each one has potential advantages over the other, which we don't necessarily need to go into. But combination therapy is going to be the way forward, I believe. Hormone therapy and chemotherapy is now standard treatment for a man with high risk, newly diagnosed metastatic prostate cancer. And those men are sometimes elderly, sometimes they're very young, in their 50s. And I've just spoken to 3 men, all in their 50s, who've got advanced metastatic disease, didn't have any symptoms at all, but now have advanced metastatic disease at diagnosis. So we need to hit these people early and hard. The only drug we have at the moment is docetaxel that's vaguely approved for it. The newer drugs are all being appraised to act as if you like, as a substitute for docetaxel. There are many men who are unable to get docetaxel because of side effects or because of their age. So there's a huge way forward. You may or may not know abiraterone has just been refused approval for use in place of chemotherapy in newly diagnosed men, as indeed enzalutamide is about to be appraised for the same purpose. So there are things happening. There are new drugs, but there are newer ways of using the slightly older drugs as well. 17% of men, newly diagnosed men, already have distant spread. It's a ridiculously bad figure that we are still not getting on top of, because these men are very often asymptomatic and we're not getting them tested early enough. Hitting them harder is a way of hopefully giving them a better outcome and certainly extending their lifespan. The new kid on the block is gene therapy. Gene therapy is not what you think it is. Gene therapy is not looking at people's DNA and cutting it up and shoving back into cells or whatever. The gene therapy for prostate cancer involves, again, it's slightly complicated, but it concerns the ability of cells to repair themselves. When a cell divides, some of those cells get damaged, their DNA gets damaged. If that damage is severe, the cell will die. So cells know this, and they have mechanisms which finds, oh, some of that DNA is in some way damaged, and there are mechanisms to repair it to keep that cell alive. If you interfere with that repair process, you will stop that cell repairing itself, you will stop it multiplying. If it's a cancer cell, you will kill that cancer cell. So it's a way of treating cancers in general. What we have is selective gene therapy. It's an ability only to interfere with repair mechanisms in cancerous cells. And it's known as targeted gene therapy. So basically what you're doing is stopping cancerous cells from dividing, but not the normal ones, because you're only affecting one repair mechanism. And it's all about PARP. Sorry, I got an itchy nose, excuse me. PARP isn't the nose that Noddy's car made, or it did do that when I read the stories to my grandchildren. It stands for poly-ADP ribose polymerase. Don't worry about it. It's the enzyme system associated with cell repair. If you interfere with PARP, you interfere with cell division. and they're known as PARP inhibitors. And the one that's currently available, or currently just about to be appraised, is a drug called olaparib. Olaparib is already in use for severe advanced breast cancer. And there are huge similarities, as you know, between certain patients with breast cancer and men with advanced prostate cancer. And the people it's useful for are those men who have known genetic abnormalities, and the ones that are the most commonest are the BRCA1, the BRCA2 gene. BRCA stands for breast cancer 1, breast cancer 2. These are used in breast cancer. Around about 15% of men with advanced prostate cancer have this genetic defect. So in some respects, they have an Achilles heel because they have a genetic defect which makes them more likely to get advanced prostate cancer. We've turned that Achilles heel into a positive because olaparib is now able to interfere with the mechanism of repair, but only in cells with a BRCA2 genetic abnormality. So in many ways, it's a two-edged sword having that genetic abnormality. Yes, you're more likely to get prostate cancer, but you have the ability now for a very specific therapy if you need it. So it's waiting nice approval. It's going to bring up all sorts of other questions about genetic counselling. There are lots of unmet needs that still occur despite 12 years. And the one that's particularly important is non-metastatic castrate-resistant prostate cancer. That's a mouthful nobody understands. Non-metastatic hormone-relapsed prostate cancer, hardly anybody understands that. And certainly nobody understands the term biochemical recurrence of prostate cancer. But basically, these are people who've had radical treatments, maybe surgery, maybe radiotherapy, and who are now had an increase in their PSA levels, put onto hormone therapy, which may have reduced their PSA for a number of years, but now their PSA is rising again. Many of those men have a fairly rapid rise, and the high-risk patients are those whose PSA is doubling within 10 months. But nobody can find any secondaries on conventional scanning. And if you want to have abiraterone and enzalutamide at the moment, you have to have proven distant secondaries on conventional scanning. There's a huge need. We know that non-metastatic castrate-resistant prostate cancer will go to metastatic cancer. About 90% of them will end up there. So it would be logical to give earlier treatment, which abiraterone certainly and other drugs are able to do. At the moment, purely on cost grounds, it's not being approved by NICE, but there are some drugs in this next year that will be up for approval for that. So it's a huge unmet need. We need to relax the rules. We need earlier and more sensitive scanning techniques. It's really summed up well by this guy. We know my cancer's growing, the PSA is going up, but why do I have to wait until it is too late for treatment to be started? And I don't see how you can argue with that. We know that these men, 80–90% of them, will get metastatic disease. So what can we do about imaging? There's a lot been happening in imaging. You're all aware of MRI and CT scanning. These are radiographic scans, if you like. They are what I would call a passive scan. They look at anatomy. They show you what's happening, the structure of the body at a particular point in time. What we want is something which looks at cell function, and that's positron emission tomography, PET scanning. When you have secondaries, what you need to do is to identify those areas of the body with the greatest activity. You don't want a passive scan, I would call it a dynamic scan, one that's actually looking at cell function, looking how active the cell is. And this is exactly what positron emission tomography and PET scans do. And they also can give you lovely, pretty colored pictures. Basically, the earlier scans used radioactive glucose. You put in a certain amount of radioactively labeled glucose. Now, glucose is the fuel for all cells. The harder a cell works, the more glucose it will use, and the more metabolites, more breakdown products of that glucose it will produce. And the PET scan was to look at something called radioactive fluorodeoxyglucose. Don't worry about it. But the more of this stuff on a scan, the higher the activity of that cell. Now, lots of cells in your body are quite active. And you can see here, there's the liver, that's quite an active area. There's the spleen, which is active. There's one kidney. What's that? That's a secondary in somebody's lung. And the art of interpreting some of these scans, or most of them in all honesty, is knowing where to look for abnormalities. To know what is normal. That's normal, that's normal, that's a bit of arthritis in the spine, whatever. But this is abnormal. So you can pick out abnormal areas of high activity. For prostate cancer, a better substance to use now is called radioactive choline, and that's important in making new cell walls. It's much more sensitive for prostate cancer cells, but it's not easy to make. It needs a big linear accelerator cyclotron thing to do it. Our supplies in the UK, as far as I understand, come from Belgium, and there have been quite considerable supply problems at times. The better technique now is called PSMA PET scanning. It stands for prostate-specific membrane antigen scanning. Now, as the title might suggest, this uses radioactive gallium, but is it specific? It should be specific for prostate cells, but it isn't, to be honest. It's picked up by lots of other cells again, and you can see here, there are the kidneys, there's the liver, there's the spleen, there's the bladder. Very strangely, this stuff is picked up by your salivary glands here, and also your tear glands, your lacrimal glands. And there you can see where the injection went into the bloke's arm. There's a bit of high dosage still in the vein there, and there's the veins coming down his arm. But it is much more sensitively picked up by prostate cells. So if you like, you can turn the sensitivity down on the machine, and you're able to pick up still very small secondaries. Here's a picture of my friend, that's Martin, and that's his PSMA scan. He went through exactly the same procedures that many people, surgery, then needed hormone therapy, then needed radiotherapy, and then his PSA started to rise again. He was just being offered hormone therapy as a blunderbuss treatment. And he said, no, I've heard about this PSMA scan. I would like to have one of those. And he actually paid for it. He had private medical insurance. What you can see here is one single big black dot. It's not that big. It's 7 millimeters across. This would not be picked up on a conventional MRI or CT scan, and it's still in his pelvis. That is a rogue lymph node. And from the markings on his skin from his radiotherapy, looking at his old scans from his radiotherapy, they worked out that this lymph node was outside the radiotherapy field that they'd used for his radiotherapy. So what he was able to have is more localized radiotherapy just to that lymph node. It saved him going on to blunderbuss hormone therapy or other sorts of therapy. And there it is again, 5 years later, he did well, but then his PSA started to rise again. And this is one of his later scans. And you can see again here, he's got another little bright spot right in front of his spine there, just in front, and that's his aorta. That's a para-aortic lymph node. Looking at his scans as well, they found a couple of other very small lymph nodes also in other areas of in his thorax, I think it was. So he couldn't have any more localized treatment, and he is now on hormone therapy, but he is on hormone therapy a lot earlier than he would have been because of the improved imaging. There's another technique called whole body diffusion weighted MRI. It's just a posh MRI for the whole of your body, but it is quite good at picking up bone metastases early, and particularly at looking at the progress of treatment on bone metastases. Conventional bone scanning is good at picking them up at the beginning, but is not a very good technique for monitoring progress of bone metastases on treatment for various reasons. There's now computer software being developed at the Marsden, which actually can give you figures for how much deposits of prostate cancer secondary you've got in your bone. So you can actually get readouts of how well you're doing. It's pretty far end stuff, but this is the future. We've talked about all sorts of things. Prostate biopsy has changed, isn't it? Or it is changing. The original ones, like me, were transrectal, scattergun biopsies. Hope you pointed the thing in the right direction and got a bit of prostate that had cancer in it. There were many of us that had relatively low-grade biopsies, but nobody could tell you whether you'd missed that bit of Gleason 10 around the corner. It was pretty awful. And also because going through the rectum is a dirty area, there were instances of infection, septicemia, side effects. Transperineal biopsy can be done in two ways. The one in which many people will have been aware is with a template biopsy, a matrix of holes placed on the perineum, so you know exactly where in the prostate that needle is going and how far into the prostate it's gone. So when you look at all of your samples properly coded, you can work out exactly where the tumor was in your prostate. Targeted transperineal biopsy is now becoming more commonly used, and that basically just uses 2 puncture holes in your perineum. And then with a good ultrasound system, you can target where those needles go. It's a clean area, much less infection risk, much less incidence of sepsis. And because it's only 2 punctures through the skin, this can be done under local anesthetic. Our specialist nurses in Reading were already being trained to do transrectal biopsies. Many of them do them. We are now training those people to do this sort of biopsy as well. New word for you, theranostics, which I suspect nobody's heard of. Well, you may have done. It's a combination, very simply, of 2 words, therapeutics, diagnostics. So it's using techniques which are normally used for diagnosis and then adapting them for the purposes of using treatment. You will know one already, bone scanning, very common, uses radioactive technetium. It's taken up by all bone cells, but obviously concentrated in areas of the highest bone cell activity. There's a typical sort of bone scan at the back and at the front from a patient. And you can see multiple secondaries. The treatment option for that is radium-223. Highly concentrated, highly radioactive, taken up in exactly the same way, in exactly the same areas as is your radioactive, low-grade radioactive technetium. So that's the therapeutic procedure from a diagnostic test. And there you are. There's the guy before his radium-223, and there he was afterwards. You may need more than 1 session of radium-223. It's not without its problems. You've got to be careful with dosages because of bone marrow cells and all sorts of other things. But it is, for some men, proving very useful indeed. However, it's only of use if you have bone secondaries. It will not be taken up, excuse me, by soft tissues, by lymph nodes, and that sort of thing. Gallium PSMA scanning we've talked about. There's another gallium PET scan, attaches to prostate cell membranes, but that's both in bone and lymph nodes. The therapeutic arm of that is radioactive lutetium. That's an element, a radioactive element, which again is picked up in exactly the same way as the tracer, as gallium is, and then locally reduces high dosage, releases high dosages of radiation. There's the PSMA scan we saw of that guy. There he is after 1 set of treatment, and you can see some of those are beginning to disappear. There he is, to look, that's how many months later? That's 3 months later. And then 5 months later, after his treatment started, I think it was his 3rd session, you can see virtually no secondary deposits at all. But the eagle-eyed amongst you will see that in his left shoulder, or it might be his right, depending which way around. It's his right shoulder. That is almost certainly not a bone secondary. He probably had an arthritic shoulder. and those arthritic cells also take up some of the gallium. So is everything in the garden rosy? No, I don't think it is. Things haven't done well in prostate cancer. Awareness. And now this may seem to people like yourselves who are as active as I am in promoting awareness, the wrong thing to say. But we are still not getting to enough men. We are still not getting enough men coming early for testing. In over 50% of men, the cancer has already spread outside the capsule. That may only be very localized spread. It may only be just outside the capsule, but what that is doing is now limiting your options for radical therapy. If you can get the tumor when it's well inside that prostate capsule, your outcomes will be better, your availability of treatments such as radical surgery will be better, your need for radiotherapy will be reduced. It is just a very different set of things. And we just got to get people coming earlier and earlier. But that's going to be a hard task when there is no national screening program. Because the PSA test is still contentious. I could talk for hours about that. And I'm not going to, you'll be delighted to know. But we are still getting the wrong message, sometimes from people who should know better. We're getting reduced rates of testing because people are saying screening doesn't work. Well, single screening we know is not ideal. What we're all talking about is routine, regular screening. And it's rate of change, which is important. It's looking at not just one figure, but what's happening. And if you look at screening trials that use a regular testing program, it reduces mortality by up to 64%. You can reduce early measurement in his 40s, can predict the lifetime rise of dying from prostate cancer. You can decide in a man's 40s whether or not he's likely to get an aggressive cancer or not, what his death rate might be. We're finding out so much. There's a lady trying to improve PSA, Paula Mendez in Birmingham. She's found lots of different sugars attach themselves to various forms of PSA. And she's using nanotechnology to try and dye those to find the ones which are associated with prostate cancer. There's an awful lot of research going on to get a better PSA test. But at the moment, I think we're stuck with it for at least another 10 years. So you've got to learn to use it properly. What has fueled all this progress? Is it clever doctors wanting to be even cleverer? Is it the government being wonderfully on the ball, the NH? No, it's not. You know that. I know that. It's people like you. It's people like me. It's charities. It's people getting off their backsides and beginning to talk about it like women did 30 years ago with breast cancer. That's what fuels the progress. People like these guys. When Stephen Fry put his video up on YouTube, the switchboard at Prostate Cancer UK, the helpline switchboard, just collapsed with overwork. It died because too many people were phoning in. 2 minutes of somebody like Bill Turnbull going on television and saying, I was a fool, I left it too late, I have advanced cancer, I have been through X, Y, Z and chemotherapy, but he's still not doing badly by all accounts. The only person that upset me, to be honest, was Rod Stewart, who seemed to want the publicity at the time and just said, I have conquered prostate cancer. He didn't really tell us what he had, what his treatments were, or how he was now. It's a waste of time. It's these people being honest. Lloyd Webber was very honest about his sexual dysfunction when he was diagnosed. What's upset me the most over 12 years? Well, I think it's this. I think it's because people don't listen to the whole message. We have a race of people that want Twitter, that want everything in 12 words, that don't read the full text of what is published. And if you don't read the whole text of something, you get misinformation. That was a statement that was a headline about 2 years ago, and on the base of it, it was true. But if you looked at the whole paper that it came from, yes, the progression of disease was worse if it was untreated. Many men went for treatment in the untreated group before their 10 years of monitoring was up. There were quality of life differences, but the PSA was only tested once. There was no serial testing, and studies using serial testing have undoubtedly shown a reduction in mortality. That's one of the worst statements, I think, that we've ever had since I've been diagnosed. A Royal College telling its members that you don't give a man a PSA test if he hasn't got any symptoms. You and I will all have spoken to men who were asymptomatic, who then went on to find they had sometimes a very aggressive cancer. This was something which led to huge numbers of men not coming for testing. And it was a statement that GPs who knew no better could hide behind when men in their 50s went and said, I would like a routine PSA test. Because, I can't do it because my college tells me not to. It's something that we have to change. We know the facts and the figures from the prostate cancer audit. It's going to take a long while to change bad opinion. It always does, but it shouldn't stop us from doing it. And like I say, I think it's been the most negative influence. That again was a headline. It could be positive, it could be negative.